Before we jump into the episode, let me ask you a question. What is your absolute favorite office supplies? It's pens, right? I knew it. I knew you said pens because we're BFFs, right? And just as important as finding the perfect pen is getting ready for nursing school by doing a little prep work in advance. And to do that, I always advise students that it's really important to set up your organizational systems. You want to review some key anatomy and physiology concepts, and really crucial, you practice your math skills before the semester starts. And that's really just the tip of the iceberg. There's a lot more, but if you do these three things, you will feel quite a bit better once classes start. And if you have some of your favorite pens in hand, you will be firing on all cylinders. But if you really want to dive into nursing school prep, then I'd love to see you in Crucial Concepts Bootcamp. It's on sale right now, so check it out at straightanursingstudent.com and click on Courses in the menu bar. That's straightanursingstudent.com and click on Courses. I hope to see you there. Well, hello there. I'm Nurse Mo, and this is the Straight A Nursing Podcast, where I teach concepts and share tips on how to thrive in nursing school and at the bedside. So before we dive into today's topic, which is more of a pathophysiology type topic, let's take a quick minute for a listener shout out. And this one goes out to Lauren, who says, I just wanted to thank you so much for what you do. I am beginning my program next fall, and I can't believe how much I can get ahead thanks to your hard work making your website and podcast. I finally found the confidence to return to school at almost 30. Lauren, congratulations for taking steps to go back to school and pursue your dream. I'm so proud of you and I'm so excited for you. Thank you so much for sharing that the website and the podcast are helping you, and I can't wait to hear from you after you start your program to hear how it's going. Okay, so today's topic is more of a pathophysiology concept, and I don't know about you, but if I'm in the clinical setting and I hear about something and I don't fully understand it, what do you think I'm going to do? I'm going to go dive in and figure it out. Now, if it's absolutely critical that I understand it right then for whatever's happening with my patient, then I'm just going to ask somebody, right? But if it's not necessarily related to my patient, it's just more of something that maybe I hear one of the physicians talking about, or I hear one of the nurses talking about, and I think, I wonder why that happens. First thing I'm going to do when I have a chance is go in and dive into the pathophysiology so that I understand it for myself and for my future patients. So if you're currently learning about advanced Med Surg topics or working in the clinical setting, you've of course heard about pulmonary embolism. And what we tend to learn in nursing school, especially maybe in a Med Surg 1 or first or second semester Med Surg course, is it's all about impaired gas exchange. And that's what we focus on, right? The patient's shortness of breath and putting on oxygen and all of that stuff. But another significant complication of a larger pulmonary embolism is impaired cardiac function, which can lead to decreased cardiac output, significant hypotension, and even cardiovascular collapse. So in order to understand that connection between a pulmonary embolism and cardiac dysfunction and severe hypotension and even cardiovascular collapse, it's really important that we have an underlying understanding of some key physiology concepts. One of those is cardiopulmonary circulation. Another is the pathology that occurs with a pulmonary embolism. And another are those factors that contribute to blood pressure. So let's first start with a review of cardiopulmonary circulation. And a great way to understand cardiopulmonary circulation is to really know that blood flow pathway really, really well. So let's go through it. So deoxygenated blood travels through the superior vena cava and the inferior vena cava and into the right atrium. So it's coming back from the body, right? It goes through the superior vena cava and inferior vena cava and into the right atrium. Blood then flows from the right atrium through the tricuspid valve and into the right ventricle. This deoxygenated blood then flows through the pulmonary valve into the pulmonary artery. From there, it goes into pulmonary vasculature. This deoxygenated blood flows past the alveoli where it participates in gas exchange. It offloads carbon dioxide and picks up oxygen. It is now oxygenated blood. So oxygenated blood returns to the heart via the pulmonary veins. It enters the left atrium and flows from the left atrium through the mitral valve into the left ventricle. The blood is then pumped from the left ventricle up through the aortic valve into the aorta, and this oxygenated blood is sent into systemic circulation where it delivers oxygen to the tissues. So the key thing to really pay attention to here is that right side of the heart. When blood is in the right side of the heart, it is pumped forward into the pulmonary vasculature. I want you to hold on to that concept as we dive further into understanding the connection between pulmonary embolism and hypotension and cardiac function. Okay, so if you need to go back and review that, rewind about 30 to 45 seconds and listen to that part again. It may also be helpful for you to look at an image showing this pathway as you listen to it. That can also really help solidify it. Next, we need to look at the pathology that occurs with a pulmonary embolism. And we're just doing a very basic look at the pathology. So a pulmonary embolism occurs when a blood clot travels to the lungs and becomes lodged in the pulmonary vasculature. This clot impedes forward blood flow and thereby disrupts gas exchange at the alveoli that are, downstream from that blood flow. It would be like if you built a dam, like if a beaver built a dam, what does that do to the water? The water is not going to flow past the dam. So anything on the other side of the dam is not going to get water flow. So that might be a helpful way to think about what's happening with the pulmonary embolism. Think of it as a dam, and the water flow or the blood flow is not going to go past it. So the alveoli on the other side of that simply aren't going to have blood flowing past them in order to participate in gas exchange. So when alveoli don't participate in gas exchange, we get hypoxia. And hypoxia causes chemical mediators to be released, and these chemical mediators cause vasoconstriction throughout the pulmonary vasculature. So we have a combination of a blocked vessel or multiple vessels and hypoxic vasoconstriction throughout the lungs, and this leads to increased pulmonary vascular resistance. So I'm going to say this all again from the top. So a pulmonary embolism occurs when a blood clot travels to the lungs and becomes lodged in the pulmonary vasculature. This clot impedes forward blood flow and disrupts gas exchange at the alveoli. Subsequently, hypoxia causes chemical mediators to be released, which leads to vasoconstriction throughout the pulmonary vasculature, not just the area affected by the clot. The combination of blocked vessels or one big vessel and hypoxic vasoconstriction throughout the lungs leads to increased pulmonary vascular resistance. Okay, I know that's a lot. We're going to take a quick pause here, take a quick break, and when we come back, we'll dive into blood pressure and then how all of these elements connect to cause hypotension and even cardiovascular collapse in a patient with pulmonary embolism.
In only 2 days, you can move your career further, faster with the Harvard DCE Professional and Executive Development Program. Advance your leadership skills, craft smarter business strategies, build your network, and move your career in the right direction. You'll earn a certificate of completion, add Harvard to your CV, and become the leader you want to be. Our intensive programs are designed to fit into your busy schedule. Attend online or on the Harvard campus. Search Harvard Professional and Executive Development to learn more.
So now let's dive into looking at blood pressure. And blood pressure is a measurement of the force exerted on the vessel wall, and it has several contributing factors. So one of those is cardiac output. Cardiac output is influenced by heart rate and stroke volume. So what is stroke volume? Stroke volume is determined by three things: preload, afterload, and contractility. So preload is the amount of stretch at the end of diastole, and it's dependent on blood volume. More volume leads to more stretch, and more stretch leads to greater contractility. Greater contractility leads to higher stroke volume and higher cardiac output. I like to think of preload as a rubber band. If you've ever gotten a rubber band out and flicked it at someone across the table at Thanksgiving dinner when you were a kid, you know exactly what I mean. The farther you pull back on that rubber band, the more stretch you have, and the faster and farther that rubber band will fly. So think of preload in the same way. More volume leads to more stretch. More stretch leads to greater contractile force. And when that contractile force is stronger, we have higher stroke volume and more cardiac output. Now, the opposite is also true. Lower preload leads to lower contractility and lower cardiac output. And then there's afterload. Afterload is the force the ventricles must work against. And then contractility is the ability of the muscle fibers to shorten and contract. Contractility, as you just learned, is closely associated with preload. So now that you've gotten an overview of all of these elements and reviewed the physiology or the pathophysiology of them, how do they connect to cause hypotension and even cardiovascular collapse in a patient with pulmonary embolism? So let's go through it step by step. It starts with a blood clot traveling to the lungs and becoming lodged in the pulmonary vasculature. Blood flow downstream of that embolus is impeded. Remember, we've built a dam, and the alveoli downstream are not able to participate in gas exchange, and the blood does not get adequately oxygenated. This, of course, leads to hypoxia. So chemical mediators are released in response to hypoxia, and these chemical mediators cause blood vessels in the lungs to constrict. We call that vasoconstriction. So vasoconstriction of the pulmonary blood vessels and that blockage caused by the embolism lead to increased pulmonary vascular resistance, or PVR. Increased pulmonary vascular resistance increases afterload of that right ventricle. Remember, afterload is the force that ventricle must work against. And if that right ventricle is trying to pump blood into the lungs, and it's having to work extra hard to do that because vascular resistance in the lungs is high, we have increased afterload. And with increased afterload, outflow from the right ventricle is reduced. The right ventricle dilates, and the septum, that intraventricular septum, it bows or flattens. So we have decreased right ventricular outflow and dilation of that right ventricle. These both lead to reduced filling of, guess what? The left ventricle. With less filling in the left ventricle, you have less preload on that ventricle. And as you learned, with less preload, you have reduced stretch, you have reduced contractility, and with reduced contractility, you have reduced stroke volume and reduced cardiac output. And reduced cardiac output leads to hypotension and poor tissue perfusion throughout the body. And if severe enough, the right ventricle can fail, and the cardiovascular system collapses, and the patient ultimately suffers a demise. So that is how all the elements connect to cause hypotension and even cardiovascular collapse in a pulmonary embolism. Want to hear that again? Let's go through it again just to solidify it. So a blood clot travels to the lungs and becomes lodged in the pulmonary vasculature. Blood flow downstream of the embolus is impeded. It's the dam that has been built. So the alveoli that live on the other side are not able to participate in gas exchange, and the blood does not get adequately oxygenated, leading to hypoxia. Chemical mediators are released in response to hypoxia, and this causes the blood vessels in the lungs to constrict. So we have vasoconstriction of the pulmonary blood vessels and that blockage, both causing increased pulmonary vascular resistance. And increased pulmonary vascular resistance increases afterload of the right ventricle, giving it a lot more force that it has to work against. And with increased afterload, outflow from that right ventricle is reduced, the ventricle dilates, and the septum kind of changes shape. Decreased right ventricular outflow and dilation of that right ventricle lead to reduced filling of the left ventricle. And with less filling in the left ventricle, you have less preload on that ventricle. With less preload, you have less stretch. And with less stretch, you have reduced contractility. With reduced contractility, you have reduced stroke volume and reduced cardiac output. Reduced cardiac output leads to hypotension and poor tissue perfusion throughout the body. And if severe enough, the right ventricle can fail, the cardiovascular system collapses, and the patient may suffer a demise. All right, so now that you see how serious a pulmonary embolism can be and that it's more than just getting some oxygen on the patient, it's really important that pulmonary embolism be recognized early so that intervention can start as quickly as possible. So before I close out, I want to share with you some key signs and symptoms of pulmonary embolism. And these include dyspnea or shortness of breath, tachypnea or an elevated respiratory rate, a cough, and that cough could have some blood-tinged stuff in it. Oftentimes you'll see frothy blood-tinged sputum as a sign of pulmonary embolism. Pleuritic chest pain is pain that is worse with breathing. That's another sign or symptom the patient could be having. You'd likely, most definitely see decreased SpO2. There could be some tachycardia with that, and the patient may even be lightheaded or have a syncopal episode. So I hope that helps you understand the seriousness of pulmonary embolism and a bit about the pathophysiology of how it connects with the cardiovascular system. I hope that you come back and join me next week where we'll be diving into dysphagia, causes of that, safety considerations, because I know you definitely want to keep your patients safe. So I will see you back here for that. And if you're not yet following or subscribed to this podcast, what are you waiting for? All it takes is a quick little click on a part of your podcast player. It's going to vary from one to the other. And then you'll be following or subscribed to the show, and you don't have to go hunting for it. Every Thursday when I release an episode, bam, like magic, it shows up for you in your favorite podcast player. So take a minute to do that, and I'll see you back here next week. Bye for now. This podcast is brought to you by Straight A Nursing, a proud member of the Airwave Media Network. For more educational podcasts, check out airwavemedia.com. And for more nursing-related content, go to straightanursingstudent.com.
As a longtime foreign correspondent, I've worked in lots of places, but nowhere as important to the world as China. I'm Jane Perlez, former Beijing bureau chief for the New York Times. Join me on my new podcast, Face Off, U.S. versus China, where I'll take you behind the scenes in the tumultuous U.S.-China relationship. Find Face Off wherever you get your podcasts.